Today, we are going to talk about trauma and PTSD and trauma-informed care, which I'm very excited to talk about this because it's very, very important in our population, in the perinatal population. But first, I wanted to start with introductions, although I feel we know each other at this point, but maybe we'll go around quick and we'll introduce ourselves. So I'm Dr. Frieder. I'm a perinatal psychiatrist. I work at Frontier and at Prison for Moms. That is a program for a consultation line for providers that need help treating their patients that are pregnant or postpartum and want to have an expert opinion about how to treat them. So patients with mental health issues. So you are welcome to call us if you need. So
I'm Amber Rogers with Mountain Pacific Quality Health and one of your trustee facilitators.
Yeah.
I'm Mary Argonis from Mountain Pacific at the Hawaii office, and I'm here for support.
Thank you.
Hi there, I'm Megan Fallon. This is Emma. I am a mental health therapist in Billings, specializing in perinatal mental health.
Thank you. What about you, Jacob?
I'm Jacob Wetzel. I'm with Partnership for Children out in Missoula, Montana. And we have a project Welcome, and that's working with postpartum and prenatal mothers.
What about you, Sarah Beth?
Hi, everyone. My name is Sarah Beth Upson. I'm the Perinatal Behavioral Health Initiative Program Officer in Montana Medicaid, based in Helena. And my grant helps to fund the Prism for Moms program.
Perfect. So let's start because I think we will have a lot to talk about. So first of all, anyone wants to say anything, any announcements? I just wanted to say that in 2 weeks is our last session. So time flies. But yeah, I wanted to remind everyone that we have one more time. Anyone else, any announcements, anything they want to say? No? Okay, so let me share my screen. Okay, so we are going to talk about PTSD and trauma-informed approaches to pregnancy and postpartum. And please, we are a small crowd today, so I would say that you can interrupt me if you want to ask any questions, like just say what you have to say and we can talk about that while we are talking. Okay, so the definition of trauma. So SAMHSA defines trauma as individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So I think it's important to know the definition and to understand that a traumatic event can have negative effects later in life. So we as mental health professionals need to be on the lookout for that and know that somebody with a history of it can have consequences from it. So in the US, and this survey that I found, actually, I couldn't find like a big survey like this from later, but this is from 2000. So I'm sure now it's more than this, but the US National Comorbidity Survey shows that 60.7% of men and 51.2% of women reported exposure to at least one lifetime traumatic event. That's a lot. And they also found that 7.8% of respondents had a lifetime history of post-traumatic stress disorder. And then we'll talk more about in perinatal what's the statistics. But why is important for us to know about it? Because trauma can affect perinatal outcomes. So a history of trauma and trauma during pregnancy and postpartum can have negative effects. So from obstetrical negative outcomes like preterm delivery, low birth weight, increase in NICU admissions, cesarean delivery, suicidality. Women with a history of trauma can have an exacerbation of symptoms during pregnancy and or postpartum and have suicidality. They are more at risk of having depression and anxiety, more at risk of having poor bonding with the baby, more at risk of substance abuse, also fetal death, more at risk of unintended pregnancies, and poor child health and developmental outcomes. So this is very important, and that's why I put it at the beginning, because we need to understand that traumatic events have negative outcomes for the perinatal population and their children. So this is a landmark study where they recognize that there are adverse childhood experiences. They did a questionnaire and they divided in 3 categories. One was abuse, physical, emotional, and sexual, then neglect, physical and emotional, and household dysfunction, mental illness, having a relative incarcerated, intimate partner violence at home, substance abuse, and divorce. And they looked if any of these have any, they check on children and if these events happen before age 18, and they looked at consequences later on. And we'll see in the next slide that there was a strong dose-dependent relationship between one's exposure to abuse and dysfunction in childhood, as measured by this ACE questionnaire and scores, and risk factors for the leading cause of death in adults, which is very important. And the ACE score was calculated based on the number of yes responses. It was a 10-item survey that had into the domains the adverse experiences before the age 18, and these were, as I said before, abuse, neglect, and household dysfunction. And what the conclusions of this study, which are very important, is that only 10% of health outcomes may be attributed to actual medical conditions or care. And in contrast, 40 to 60% are attributed to social and behavioral factors, which is such a big number. You know, think that 40 to 60% of negative outcomes in your health can be related to social and behavioral factors. So in terms of post-traumatic stress disorder in pregnancy and postpartum, there are 2 situations that you can see. You can see women that have a history of abuse in childhood, sexual abuse, physical abuse, emotional abuse, or women that had a prior pregnancy with a traumatic event during that pregnancy and postpartum. Or it can be other traumatic events in different times of life. But they found in this study that PTSD was associated with women who had a previous complicated delivery. So that we see it a lot. I'm sure you see it too, that women that had a prior complicated delivery will come to you and they can have symptoms associated to that delivery in this, with the current pregnancy or postpartum. And it can really affect the woman's in many ways, you know, and we'll talk more about this, but it can affect their future childbearing decisions, ability to breastfeed, and relationships with the baby. So traumatic events can lead to avoidance of the baby. Also about, in the literature, is described women that decided to get sterilized because they don't want to have children because of the re-experiencing of trauma during pregnancy and postpartum. It can affect their decisions about their sexual relationships. It can lead to request of termination of an unplanned pregnancy, or as I said, sterilization. some children avoid contact, some mothers avoid contact with their children for many years, as this can trigger some PTSD symptoms, and that can increase isolation. And women with history of sexual abuse may re-experience abuse during childbirth procedures or during internal examinations. That's very important for us to keep in mind, because when we see as mental health providers these patients, we need to understand that they are going through pregnancy and postpartum, and they will go through certain procedures during their OBGYN visits that can trigger them. So this is about the prevalence of PTSD in pregnancy and postpartum. And this is a systematic review and meta-analysis of PTSD, and reported a prevalence rate of 3.3% during pregnancy and a further 4% of postpartum PTSD. And this was mostly in relation to traumatic events during birth, prior birth or current birth. But the prevalence is greater in high-risk populations, such women with severe complications in pregnancy or during childbirth. And the rates, as you see, are much higher, 15 to 18%, after a premature birth, after emergency C-section, or after stillbirth. So the risk of PTSD is much higher when you have complications of pregnancy or postpartum. But one thought that these authors had is that this prevalence is underestimated because they only examine the risk of associated to traumatic childbirth experiences and not to other experiences that can happen during pregnancy or postpartum. So one thing that I think is very important to talk about is that how trauma interrelates with healthcare. So women with history of past trauma are at more increased risk of substance abuse, depression and anxiety, being in the moment, having like domestic violence at home. And some of them might have poor interpersonal relationships and trust issues with people and systems that may be important for the person's well-being. So when they are in touch with the OBGYN clinic or the psychiatric clinic or whoever is the health professional that is seeing them, they might have difficulties in how they relate to them and the trust because of their past history of trauma. Then, as I mentioned before, it's very common to have re-experiencing of past trauma during physical examinations, and more in OBGYN, that some of these examinations can be invasive. And unfortunately, in the healthcare system, there is limited knowledge on how to approach women with trauma history. And there is a lack of knowledge on how to recognize even, trauma and PTSD in the OBGYN settings, and we'll talk more about that. So there is an approach that is trauma-informed care, and it acknowledges the need to understand a patient's life experiences in order to deliver effective care, and has the potential to improve patient engagement, treatment adherence, health outcomes, and provider and staff wellness. Because when a patient with trauma comes to the clinic or to you as a health professional, it not just affects her, but it can affect you too. And many of these women might not be adherent with the treatment because they don't want to deal with the health system when they feel that the health system might be traumatizing too. So learning how to engage them and how to improve adherence and how to help them trust you, it's a big concern. Also, when somebody comes with a traumatic event, and more like as a mental health professional that you hear to these women talk, that can be traumatizing to you because they can tell you things that are very upsetting, and that can be very hard to hear. So there needs to be a system in place where the staff is also protected. So trauma-informed care, the important things about it is that you have to realize that the impact of trauma is widespread and understand potential paths for recovery. You need to recognize signs and symptoms of trauma in the patient, in the family, and the staff. You need to integrate knowledge about trauma into policies, procedures, and practices. And you, very, very importantly, you need to actively seek and actively try to not re-traumatize the patient. So, for example, avoid creating an environment that inadvertently reminds patients of their traumatic experiences and causes them to experience emotional and biological stress. That's why I mentioned a lot the internal examinations in OBGYN. That can be very, very traumatizing. So the changes need to be done at an organizational level and also at a clinical level. So first of all, leadership needs to be aware of this and bring resources to help the staff, to train the staff, both the clinical and non-clinical staff, because women can get re-traumatized when they come to the clinic, and if the front desk person is not aware and might say something that triggers them, that can be re-traumatizing. So we need at the level of the organization, we need to communicate and transform all the process. And it's very important to engage patients in the organizational planning, so to have their feedback on how to make things better. And always create a safe environment, and that can be done by keeping places like the parking lot, the restrooms, the hallways with a lot of light, avoiding people congregating in front of the doors of the clinic, making it a safe place for the patient. And as I said, preventing secondary traumatic stress in staff, that's very important because the staff will give care to these patients. So you need to have them well and not traumatized by the experience of the patient. Also, some staff has their own trauma. And when they hear to the trauma that the patient brings, that can be traumatizing to them. On the level of the clinical practice, it's very important to involve the patient in the treatment process. It's always important to tell the patient what you are going to do and to make them active participants in their care, but more so in patients that have a history of trauma. So always you have to look for trauma, you have to screen for trauma, you have to train your staff to know how to deal with trauma, and have good referral sources, in terms of like what you do with these women. If they come to the OBGYN clinic, they have PTSD, you recognize a history of trauma, where are you going to refer that patient for psychotherapy, for medication, for group therapy, whatever you think will be important. And then there are some treatment approaches that have been shown that are helpful, and here I wrote some of them, like prolonged exposure therapy, where you help the patient go through the trauma while teaching them like breathing exercises or things that they will help them deal with the physiological responses. EMDR is very helpful for trauma. Another approach is seeking safety, like prioritizing the safety of the patient in terms of making patients feel that they can look for their safety, that they can create their safety place. Then if it's a child-parent psychotherapy can help, working with attachment, self-regulation, and competency, and trauma-focused core behavioral theory, where you deal with the distorted thoughts that the patient might develop after the trauma. So you try to change that and to more helpful thoughts, and also deal with the trauma. that the patient dealt with. So I thought it will be important to keep time to talk about all this because this is very important, and at the level of us seeing the patients, but also at the level of organizations and clinics. And like, I have so many patients in mind that dealt with the system and got re-traumatized. So I thought it's important to talk about all this. Any questions?
I had a quick question. So if we're working with mothers who have like trauma in their life or trauma that they've experienced in the background, so like within a clinical setting, within like a hospital or something, I know we talked about like certain exams can be re-traumatizing. Is there anything that's like documented within like their case or file that would let a clinician know that they may have experienced these things? I really don't know. That's why I'm asking. So I would maybe assume not, but
I agree. I think it depends where you go. Like if you go to a behavioral health clinic, it's more likely they ask about trauma. I was reading about when to ask about trauma. And some places they say ask initially, in your initial evaluation, and have that in mind and kind of address that. But other places suggest, no, first establish a rapport with the patient, make her feel trust for you, and then ask for trauma. And I think what I'm trying to say is that a lot of places don't ask, and they don't know. And women can come to them and there's nothing in the chart. Nobody knows about their trauma and they are just approached in a certain way, and that can be re-traumatizing. So I think the biggest thing is that there has to be more awareness of how prevalent trauma is, and women need to be asked the question. And what I do a lot in my practice is that when I meet them the first time, I always ask, but I say, we don't need to talk about the details. And I don't want you to start telling me now about your trauma if you don't feel comfortable. But I just want to know if you ever lived anything that you experience as traumatic, And I think you give them the door to talk about it, but if they don't feel yet comfortable with you and they don't want to talk that time about it, that's okay. But at least
Well, and one other thing too, Dr. Frieder, sorry, my audio is being weird today, so I'm talking through my phone. This is Megan though. One of the things that I have found helpful is just that ACE score and being able to complete the ACE score. And I know in Montana, there's been a big push for that to be more widely used across, mental health and medical settings. And so even if somehow, medical professionals could incorporate that into just standard practice, we don't have to go into a lot of detail, but it just gives those really quick questions so we can at least be on the radar that yes, something happened. Oh, you're muted, Dr. Frieder. Oh, there you go.
Yeah, no, I totally agree. And I think there needs to be a way of kind of flagging those patients, like that the provider knows. And what I said about, it's not just the provider, it's also the non-clinical staff. And, like I had recently a patient that had a stillborn, and then she went to her OB appointment later on because she had some physical symptoms. And the front desk staff and also the nurse asked her, how is your baby? So that can be really upsetting. And that woman later on avoided going back to the hospital, avoided going back to the OBGYN. So it needs to be, there needs to be like a way of that the providers, and not just the providers, that everybody is trained in trauma and everybody knows about it in a way that they are all cohesive in how they respond to these patients. And
yeah, and in that particular, this is Megan, in that particular case, Dr. Frieder, I know the practice the doctor recently had a conversation with her, and it has provided a lot of, I think, education and training on their end with like the nursing staff and the receptionist. But unfortunately, she was the guinea pig. And there continues to be, you know, experiences that are re-traumatizing. And I think the other thing to keep in mind too, like these patients, especially after something as traumatic as like a stillbirth, are so vulnerable. Yeah. And even if the providers and the clinicians, if everyone acts and, you know, with the best intention, sometimes things are so just acutely misinterpreted, and they're so hyper-vigilant. And so sometimes it's not even intentional.
We can't hear you.
Uneducated, but their information is misinterpreted.
Megan, we couldn't hear the last part, what you said.
I'm sorry, can you say that again? My audio suddenly started working.
No, that we couldn't hear your last part, what you said.
Oh, I'm sorry. So what I was just saying is, you know, just because these clinicians these patients are having such a traumatic response and they're so hypervigilant, even if all the staff act in their best interest, sometimes it's still not enough.
That's right. That's right. So I was wondering if anyone has any case or.
Well, Dr. Frieder, I actually have a question. So I guess so besides the ACEs score, is there like any other like validated screening tool for trauma that you recommend?
There is. I don't really use any screening. I go through the different criteria of PTSD when I see patients, but there is, I think it's the PTSD-5 it's called. Like there are some screening tools,
yeah,
you know.
The PCL-5 is what I use aside from the ACE. And that's free, you can find it online.
Yeah. And I think, you know, using days, it's very, very helpful because it kind of compromises a lot of domains, you know, and just asking, you know, just giving people to feel and say, okay, did you have trauma in these areas? You don't need to get into details about it. Just, you know, that they lived those things when they were younger, you know. So I was wondering if anyone, yes.
I guess I have a question. So from like a medication standpoint, what would you say is kind of your go-to for treating some of those more traumatic symptoms of flashbacks, nightmares, hypervigilance, acute anxiety, that kind of stuff?
So that's a great question, you know, like, so we use a lot the SSRI for trauma, for PTSD, and some of them can have a response. But what we deal a lot is with the nightmares that don't seem to respond. Actually, SSRIs can give you more vivid dreams, so that can be a problem. One medication that is very helpful for that is prazosin, that we give it, and it really helps with the nightmares associated with trauma. So
is that safe during pregnancy, prazosin?
It's, you know, it's a risk benefit, and yes, you can use it. You can use it. There's not so much information about it in pregnancy, like the SSRIs, you know, but some women need it and has been used. Any other questions? Anyone that wants to talk about the case? So I can talk about the case. So I'm trying to think which one. So one thing, it happened, you know, when they say that you actually, in clinical practice, you see more than one at the same time, you know, like they don't come isolated. So I had two patients actually in a short period of time that came in the postpartum, but after they had a pregnancy, a twin pregnancy, and one of the babies died in utero at the beginning of the pregnancy. And they had to carry that pregnancy to term because they had a live baby in their womb. So they came to me later on in the postpartum because they were having symptoms, not just of PTSD, but of depression, a lot of depression after living a pregnancy where one baby was alive and one baby was not alive. And that was very traumatic, because they didn't know if to connect to the pregnancy, if not, they felt guilty when the baby was born that the other one wasn't alive, So that started making me think about these particular cases, like how do you deal with them psychologically? But I thought that experience can be very traumatic, because we see a lot of the stillborns, we see sometimes infant death, like in the first few months, and that's very traumatic too. But I thought this is a particular way of trauma where you have one baby and the other baby is not alive, So, and I had two patients in a short period of time with that experience, and one was clearly depressed with an episode of postpartum depression and feeling very guilty, didn't know if she should be happy or not, if she should connect with the baby, what if this baby dies too, The other patient came like, I didn't know if she was psychotic when I met her. She was postpartum. She couldn't talk about her pregnancy. I didn't know what was going on. She had a flat affect, very disconnected. And yeah, later on, the first session, I just was supportive and there for her and let her talk, whatever she needed to talk, but I didn't know about this experience that she had until later on. She felt more comfortable and started opening up and saying how she had a twin pregnancy and one of the twins died. And in those pregnancies also there is complications, and you don't know if the second baby, the baby that is alive, will have any complications because of the loss of the first one. So she was all the pregnancy worrying about what if the second baby dies too. And she was clearly having post-traumatic symptoms because in her it was experienced as numbness, hyper awareness, hyper vigilance. Like once in the clinic, we asked her to fill a questionnaire, and one of the questions was how many children you have, and that totally triggered her and brought flashbacks. And so I think that, going back to your question, Jacob, is that it's so important to keep in mind that people can have traumatic experiences and how you ask things, how you, because the most minimum things that you think it can't be traumatic can traumatize people, So yeah, I'm thinking about that, and there are so many cases that it's so prevalent, it's really, really so prevalent. I think last week I saw a patient that lost her baby to SIDS, and she was so upset, I think in her case it was an acute stress disorder, but she was dissociating, she couldn't sleep, she was hyper vigilant about her other children, thinking they will die. So yeah, so these are experiences in pregnancy, but if you think about the women that come with a history of trauma from childhood, and then they might experience something during pregnancy or in the postpartum that can be really re-traumatizing. And one thing I wanted to mention that maybe I didn't mention in the slide is when the relationship with the provider can be traumatizing. You know, like a lot of women feel loss of control during their delivery. A lot of women feel not understood or like told what they have to do. So one thing that I think is very important is to do a birth plan before they have a baby. And even though the reality might be that they can't really comply with their birth plan, but at least if they can think through the delivery, if they can think about the possibilities, if they can at least accomplish one thing in their birth plan, you know, so they can feel in control. Because I think a lot of times it's the feeling out of control that is very triggering for women. Or, you know, feeling not understood. Like I see it a lot in the African American population, you know, like feeling not understood by the providers and feeling traumatized or re-traumatized during deliveries. So I think that's important to keep in mind. And I think then it's where the training for the staff is so important, because providers need to learn how to deal with these women. Not just these women, anyone deserves an explanation, deserves an understanding of what they are going to go through, deserve feeling control, you know? So I think that's important.
This is Megan. I think another thing too you're talking about, just how pregnancy in itself can be triggering for some of these patients. I have a client right now who has a history of childhood sexual abuse. And then she's had like a lot of pelvic floor issues, a lot of pain with intercourse and incontinence, and she's done pelvic floor therapy in various capacities for years. And so just getting pregnant, and then like the first vaginal exam was so triggering for her. And so we had to do just we actually did some EMDR with her, but just like a lot of breath work and a lot of prep for those appointments, because she goes into these appointments with these providers and she's just so overwhelmed, and no touch is safe touch for her. And so it took a lot of planning, and it took a lot of planning for her and her partner too to get pregnant, just because we know how her sexual trauma plays into all of this.
I think Naz was trying to say something and her audio is not working. So one thing I agree in terms of the EPDS, it's helpful for red flags, you know, like with that you can screen for depression and anxiety, and it's a good way of starting a conversation, you know, and seeing what's going on, why the woman feels that way, and it's a way of approaching and kind of figuring out if there is any trauma. And yes, I agree with you. We see so many women with history of sexual abuse as children, you know, by family members. So that's so important, because if you can't trust your family member, could you trust the healthcare professional or the health system? And during a time of your life that the care you are going to get is so invasive, you know, like they are going to touch your body, inside of your body, they are going to take a baby out of you, like it's very invasive. So I think it's so important to always listen to the patients and not assume anything, because their experience can be so different or so in a way that you didn't think about it. And also it can affect, I think I mentioned in the slides, like trauma can affect breastfeeding, you know, like I had a patient that had trauma, sexually abused as a child, she remembered it in her breast, you know, so every time she tried to breastfeed, it brought flashbacks of her abuse. So that really made it difficult. for her. And yes, I agree, Naz, that invasive seems to be the common theme for the sexual abuse survivors. Yes. Yeah. What else? Any questions? Anything you want to comment? I think that we are all aware of this and we all deal with these women. You know, there is a lot of ways of the way women deal with trauma. You know, some of them deal with substance abuse. So there is so much substance abuse as a way of dealing. It's like I see it a lot. And one of the things we talk about is that they are self-medicating, you know, they are trying to deal with their negative feelings and memories and trying to numb what they feel with their substances. So I'm sure many of you see that too.
I'm trying to call in through my phone. I don't know if you can hear me.
Yeah, Naz,
Nah,
we can
this
hear
is
you.
Naz.
Yep.
Okay, so I think one interesting thing that came up recently is these two survivors of childhood sexual abuse, and the abuse was by their biological fathers. So they have been struggling with these thoughts of what if this makes them a perpetrator towards their own children when the children are older, you know? So they're just afraid, like, if this was done to me, what if I do this to my child?
That's a great point, actually. Yeah, it's like that's what they learned, you know? So how do they know it won't happen in their interactions with our children? But I think that's where empowering them is so important, you know? And explaining and a lot of education, you know, and women that can say that and can have that thought is because they are a step ahead, you know, they are thinking about it, and that's so important.
So
Well, yeah,
I also like this conversation just brings up a lot of cases from when I used to do home visiting, and not being like, you know, a medical provider, but still supporting women in the pregnancy and postpartum period. And I think too, like something that is still not really talked about a lot is, you know, the trauma that partners go through when they like when they're, you know, like spouse or girlfriend or whoever is have like going through like like having these flashbacks, going through these things. And you know, a lot of the times it manifests as postpartum depression in those partners, or you know, or it comes out in other ways, but that's not like routinely screened. And I think that that's something that, as you talk about like having system change and hospital change, like that's something that, you know, I would always encourage like different provider practices and organizations to start routinely screening the partners that come in, even if they only come in, you know, during a couple pregnancy appointments or in the postpartum appointment, or even we, you know, Montana Medicaid also reimburse for any caregiver that goes in for the pediatric appointments. That's reimbursable by Montana Medicaid for moms and dads and grandparents and any caregiver. And it's something that could catch something early on that usually, you know, leads to a lot of relationship issues later on. So I think that this, you know, and it also trauma can come up for partners just on their own during the pregnancy period. So it's just something that I thought of when this was all talking about.
I totally agree. I think that's so important, you know, like, and like just sometimes seeing the mother depressed can be traumatizing, you know, to the partner. So I think always screening for any psychiatric illness in the partner is so important. And also because we know that when the main support person is not doing well, that has a high impact on the mother, you know? So if you want to have a good pregnancy, good postpartum, improve the chances that the baby is okay, you know, you need to look also at the partner. And there are studies that show if that, like if the partner is so psychiatrically, let's say, unstable, that is a biggest risk for the mother to be admitted to the hospital, you know, for psychiatric reasons. So yes, I totally agree. I think it's not just the patient, it's all the important people in her life that will support her, you know, and that baby that will take care of that baby. I always ask about the partner. How is the partner doing, you know, like in the pregnancy, in the postpartum? I think it's so important to know. And because sometimes they need help and you can help facilitate that, you know? And I think we spoke one of these sessions, like when it's the partner has, like in postpartum depression in men, you know, and it's shown differently, you know. So some men might use more substances, they try to self-medicate with alcohol, you know, they might tend to be more aggressive, more irritable. That's how they show their depression, you know, instead of saying, I'm depressed. So it's important to keep that in mind and help them, because that can affect everyone in the family. Any other thoughts? For me, the question is also how, when somebody comes to see you, when a woman comes to see you, I'm thinking of a particular patient, you know, with substance abuse, like alcohol, meth, you know, the kids were removed and then given back to her. And I'm thinking, where do you start? You know, and she has a history of trauma, you know, like pretty severe. And where do you start in the treatment? What do you treat first, you know, or how do you help them so they can feel better? Because she's depressed, she's abusing drugs, you know, she doesn't trust me because of it, you know, like I'm the healthcare worker, so what if I call CPS on her again, you know? So she's very careful on what she's telling me. So I wonder if you have any thoughts of how do you approach, you know, those kinds of situations.
I mean, this is Megan again. I think, you know, my first approach, first and foremost, is just building that relationship. Non-judgmental, you know, I'm not an authority figure, you know, and obviously I talk with her about mandatory reporting, all of that. But I try to align with the client and let them know, like, if I ever feel like I need to make a report, I'm going to do it with you. And you're going to be in the room with me and you're going to hear everything that I have to say. And you can be part of this as well. And just try to join with them as much as possible and help them feel included and like they're part of the treatment. And I'm not necessarily this authority figure or this like expert or professional that's above them. And I find that's really helpful in getting that initial buy-in at least.
Yeah, I agree. I think the key is like to be non-judgmental, you know. I saw a patient today that came for an evaluation for medication in pregnancy. She's preconception, and she's smoking a lot of marijuana, a lot. And she didn't tell her prior psychiatrist that she was smoking marijuana because she felt that she will be judged. You know, she told me he was an old white male and I felt judged. You know, I didn't even try to tell him. And when we made a plan for what to do now that she wants to get pregnant, I said, first of all, we need to work on decreasing the cannabis use, you know, because that can also affect the fetus. So we need to start with that. We'll do it stepwise. And she was so guilty. And I said, you know, like, I understand where you're coming from. You know, I understand your past history. And that was the best you knew how to do at the moment, you know, how to treat yourself. And she was like, thank you for not being judgmental. And I thought that's what we are supposed to do, no? Yeah, you know, like, but I think it's so important that we can't take it for granted, you know, and that is one of the bases of the trust. It's like being non-judgmental when patients tell you their story. And yes, and establishing the trust, and, you know, I think in that sense, being a mental health provider, you have, how do you say, you are ahead, because you are not going to see that patient for one time. You will see them over time. You have time to establish a relationship, you know, and that will help with exploring the trauma and helping to deal with it. What would you say? What is your, in terms of your patient population, like how much have a history of trauma?
I'd say a great deal of the mothers that we'll be working with have a history of trauma, especially the population we're really kind of trying to target right now is mothers living in the YWCA here in Missoula. So they could have gotten there in various reasons, but absolutely, this is definitely gonna be a huge part in kind of how we try and find care for them and find resources.
Yeah, and I agree. I think that's really like in every setting, you know, that it's more than what we can think the amount of trauma there is. But I also, I was reading what Megan wrote, and yes, there is the big T and the small t of trauma, you know, so it doesn't have to be a big event, you know. I think a lot has to do with how the woman experienced it and what she experienced as traumatic, you know, and it can be like small events that happen several times, you know, that can be traumatizing.
Well, and one thing I often see, you know, talking about this small t trauma is so much relational or attachment trauma, especially with, you know, early childhood, you know, their childhood caregivers. And so a lot of women, once they're pregnant and then they're in that postpartum infant stage, thoughts and memories and feelings related to their childhood and their relationships with their parents and their relationships with their mother